Welcome to the deep dive. Today, we're taking an incredible journey right into the core of what keeps us alive and thriving, your cardiovascular and respiratory systems.
Yeah, that's right.
We've gathered a comprehensive blueprint of knowledge, everything from how your heart pumps blood so meticulously to how your lungs just effortlessly draw breath.
Hmm.
And our mission today is really to distill the most vital insights for you. Think of it as your fast track to understanding the incredible engines inside your own body.
And hopefully with some surprising facts thrown in.
Exactly. Enough to keep you totally hooked.
It's true. The source material we're diving into is just incredibly rich. It lays out, the fundamental anatomy, the really intricate electrical and mechanical workings,
And even the common problems that can pop up.
right, the disorders. But what's truly remarkable and what we'll really focus on is just how profoundly interconnected these systems are.
Yeah, that connection.
Even a seemingly small change in one system can send these ripple effects throughout the entire body. So I was going to pull back the curtain on these complex ideas.
Make them crystal clear.
Yeah, make them clear, show you not just what happens, but kind of why it matters to your everyday life.
Okay, let's do it. Let's unpack this blueprint and discover the fascinating mechanics behind every single beat of your heart and every breath you take. Let's kick things off with the undisputed superstar, your heart.
Can't start anywhere else, really.
It's so much more than just a muscle. It's this precisely engineered, tireless pump. We're talking 4 specialized chambers, 4 perfectly timed valves,
Mhm.
and this elegant closed-loop pathway for blood that really is just a marvel of biological engineering.
Absolutely. And if we step back and look at that bigger picture, the heart's ingenious design ensures that oxygen-core blood is always directed straight to the lungs,
Right.
while the oxygen-rich blood gets sent out to the rest of your body, and crucially, they never get mixed.
Super efficient.
It's incredibly efficient. Think of it like a perfectly choreographed dance. You've got the deoxygenated blood, right? It's done its job delivering oxygen.
Comes back from the body.
Exactly. Comes back from the body into the heart's upper right chamber, the right atrium. Then flows down into the lower right chamber, the right ventricle,
And that pumps it to the lungs?
pumps it off to the lungs to grab fresh oxygen. Once that blood is oxygenated, it flows back to the heart, enters the upper left chamber, the left atrium.
And a big one.
Then the powerful left ventricle, which gives it this mighty squeeze, sending it out through the body's main artery, the aorta, to nourish every single cell. It's just elegant.
It really is. So beyond just beating, how much vital work is your heart actually performing, say, every minute? This is where we get into some key numbers that give us a real sense of its pumping power.
Yeah, and this raises a really important question. How do we actually measure the heart's output?
How do you quantify that?
We look at something called cardiac output, which is essentially the total amount of blood your left ventricle ejects out to your body every minute.
Every minute.
And
Okay.
it's a combination of 2 things.
Yeah.
Your heart rate, just how many times it beats per minute, and stroke volume.
Stroke volume. Neat.
That's the amount of blood it pumps out with each individual beat.
Yeah.
But, it's not just about the volume.
Right. There's more to it.
We also consider preload. Think of preload as how much the heart muscle stretches right before it contracts, like stretching a rubber band to give it more snap.
Okay. The pre-stretch.
Yeah. And then there's afterload. That's the resistance your heart has to overcome to actually push that blood out into the system.
Like the pressure in the pipes it's pushing against.
Exactly like that. So these factors together, cardiac output, stroke volume, preload, afterload, they give us this really comprehensive picture of how well your heart is working, adapting, performing under different conditions.
So with all this intricate work happening constantly, how do we know if this incredible system is actually performing the way it should? What are the key clues we look for to assess cardiovascular health?
Well, what's fascinating here is that it's really a multi-pronged approach. It's not just one test.
Right.
We combine, your personal health story, your history, with a physical exam, and then add in objective lab tests and diagnostic tools to paint the complete picture.
So starting with risk factors.
Exactly. We look at both modifiable risk factors, things you can change, like smoking, diet, activity levels, and the non-modifiable ones, like your age or family history,
Things you're stuck with, basically.
pretty much. Then during a physical exam, we might observe your skin for color changes, check for any swelling, or maybe notice how the veins in your neck look that can tell us about fluid status.
Okay.
We also gently feel your pulses, check your skin temperature, see how quickly blood returns to your capillaries, maybe by pressing on a nail bed.
Capillary refill, yeah.
Listening to your heart sounds with a stethoscope tells us if your valves are opening and closing properly, or if there are any unusual sounds, like murmurs.
What about blood pressure?
Crucial. We take blood pressure readings, including orthostatic measurements. That's where we check it lying down, sitting, and standing to see if your body adjusts properly when you change positions.
Ah, to see if you get dizzy standing up.
Essentially, yeah. And then, for really specific clues about heart muscle damage, we have lab tests like troponin.
Troponin, I've heard of that.
Think of troponin as a super sensitive alarm for your heart muscle. If those levels are elevated, it means there's been some damage, like during a heart attack.
A clear signal.
A very clear signal. And finally, an ECG, an electrocardiogram, gives us that visual snapshot of the heart's electrical activity. It can reveal anything from rhythm problems to signs the heart is under stress or not getting enough oxygen.
Okay, this is where it gets truly fascinating for me. Your heart isn't just a pump. It has its own, sophisticated, built-in electrical system.
It really does.
It makes it beat automatically, completely independent of your brain's conscious commands. It's like it has its own internal conductor.
That's a great way to put it. And it raises that important question. How does the heart coordinate its contractions so perfectly to ensure blood flows efficiently?
Yeah, how does it do that?
It's all thanks to these specialized cells, pacemaker cells, that generate electrical impulses and then transmit them in a really precise sort of domino-like sequence.
Oh, okay.
It all starts with the sinoatrial node, or SA node. People often call it the natural pacemaker of the heart. It sits up in the right atrium.
The top right chamber.
Right. And this node initiates the electrical signal, typically firing off 60 to 100 times per minute in a healthy heart.
The normal rate.
Exactly. That signal then travels across the atria to the atrioventricular node, the AV node. The AV node acts like a gatekeeper.
A gatekeeper? How so?
It slows down the impulse just for a fraction of a second. And this pause is crucial. It allows the atria, the top chambers, to fully contract and give that little kick of blood down into the ventricles.
Before the big pump starts.
Precisely. Before the ventricles contract. From the AV node, the impulse then zooms down through the bundle of His and then into the Purkinje fibers.
Purkinje fibers?
Think of them like electrical superhighways. They rapidly spread the electricity throughout the ventricles, causing them to contract really powerfully and eject blood out to the lungs and body.
Wow. So it's this beautifully orchestrated electrical wave that triggers the mechanical squeeze.
Perfectly put. Electrical event leads to mechanical action.
So when you see those squiggly lines on a heart monitor, the ECG, what are they actually telling us? Are they just random squiggles?
Not at all random. They're a visual representation of that very electrical symphony we just described.
Okay.
And what's truly insightful here is how each little bump and dip on that ECG trace tells a specific part of the heart's story for that beat. It's a real-time, non-invasive window into your heart's electrical health.
Break it down for us. What do the different parts mean?
Okay, let's look at the main components, the PQRST complex.
PQRST.
The P wave, that first little bump, that's your atria squeezing. The signal reaching the top chambers, getting them ready to push blood down. Think of it as the heart getting ready beat.
Atrial contraction. Yeah.
Then the PR interval, that slat line after the P wave. That's the brief pause we talked about, the signal passing from the top chambers to the bottom ones via the AV node. It's like the heart saying, hold up, let's make sure the ventricles are ready.
Got it. Pause.
Next comes the big spike, the QRS complex.
Yeah.
That's the powerful main event. Your ventricles squeezing, contracting forcefully to pump blood out to your entire body. This is the big power pump. Ventricular depolarization.
The main squeeze.
Absolutely. Following the QRS is the ST segment. This is when the ventricles begin to relax after their big squeeze. It's like a quick, take a deep breath, rest is coming.
Starting to reset.
Exactly. And finally, the T wave, that last broader bump. This signifies the ventricle completely relaxing and refilling, getting ready for the very next beat. Ventricular repolarization. It's the all done time to reset for the next squeeze part.
Wow. So much information in just one beat.
Right. And when all these waves look just right, the timing between them is perfect, and the heart rate is between 60 and 100 beats per minute, we call that a normal sinus rhythm.
Meaning everything's electrically normal.
Exactly. The signal starts in the SA node and follows that perfect pathway every single time.
But sometimes that carefully orchestrated electrical symphony gets a little off-key.
Unfortunately, yes.
Leading to what we call dysrhythmias. And these can range from, minor, barely noticeable hiccups to really serious life-threatening emergencies. So what does it truly mean for someone when their rhythm goes wrong?
That's a crucial point. It raises the question, why do these various rhythm disturbances happen, and why are some so much more dangerous than others?
Yeah, why the difference?
It almost always comes down to how effectively the heart can actually pump blood to the body when its rhythm is disrupted. If the pump isn't efficient, the body doesn't get the oxygen it needs.
Makes sense. So what are some common examples?
Okay, let's start with some relatively straightforward ones. Sinus tachycardia is simply a faster than normal heart rate over 100 beats per minute. But importantly, the electrical pattern, the PQRST, is still normal.
So just fast.
Just fast. It's often just your body responding normally to things like stress, pain, fever, or maybe low blood volume.
Okay, and the opposite.
Sinus bradycardia. That's a heart rate below 60, but again, with a normal electrical pattern. Now, this can sometimes cause dizziness or fainting if it gets too slow to perfuse the brain properly.
But not always bad.
Not always. It can be quite common, even normal, in highly conditioned athletes whose hearts are just very efficient at rest. Or it can be caused by certain medications or even vagal stimulation, like straining.
Okay. What about faster, irregular rhythms?
Right. Things get more complex. You have supraventricular tachycardia, or SVT. Here, the heart race is very fast, sometimes 150 to 250 beats per minute.
Wow, that's fast.
Very fast. It's usually caused by an electrical short circuit or loop originating above the ventricles. The QRS complex is usually narrow, and the P wave might be hard to see. You can feel like your heart is just pounding out of your chest.
Is that dangerous?
It can be, especially if the person becomes unstable, meaning their blood pressure drops, they feel faint, or have chest pain because the heart is beating too fast to fill properly. In those cases, immediate action is needed, like specific vagal maneuvers, medication like adenosine.
Adenosine, I've heard that one briefly stops the heart.
Yes, it causes a very brief pause, which can be scary but often resets the rhythm. Or, if they're unstable, synchronized cardioversion might be needed.
We'll get to cardioversion later. What about AFib? That seems common.
Atrial fibrillation, or AFib, is indeed very common, especially as people get older. And it's really important to understand, in AFib, the atria, the top chambers, aren't contracting effectively. They're just sort of quivering chaotically. You don't see a clear P wave on the ECG.
It's quivering.
Yeah, disorganized electrical activity. This leads to a very rapid and crucially irregular response in the ventricles. The beat feels erratic.
So the main danger isn't just the fast rate.
Often, the biggest concern with AFib isn't just the rate itself, though that needs managing. It's the risk of blood clots forming in those quivering atria because blood isn't flowing smoothly.
Clots.
Exactly. Those clots can then travel, often to the brain, causing a stroke. That's why people with AFib almost always need anticoagulation blood thinners alongside managing their heart rate and rhythm.
That makes sense. And then the rhythms can get even more precarious, right? Affecting the ventricles themselves.
Absolutely. And when the rhythm disturbance originates in the ventricles, the main pumping chambers, the stakes get much higher because they're directly responsible for pushing blood out to the whole body.
So what happens then?
Well, you can have premature ventricular contractions, or PVCs. These are basically early extra beats coming from the ventricles. Most people feel these as a skipped beat, or a flutter in their chest.
Are those dangerous?
Often, they're benign, maybe triggered by stress, caffeine, alcohol, or electrolyte imbalances like low potassium or magnesium. But if they happen very frequently, or in certain patterns, they can sometimes signal underlying heart issue or increased risk.
Okay, what's more serious?
Ventricular tachycardia, or VTAC. This is a dangerously fast rhythm, 100 to 250 beats per minute, originating in the ventricles. On an ECG, it often looks like a continuous chain of wide, bizarre shapes, sometimes described as ghosts or tombstones.
That sounds bad.
It is. VTAC can quickly escalate. Now, there's a crucial distinction here based on whether the patient has a pulse.
Pulse or no pulse?
Exactly. If the patient has VTAC with a pulse and is stable, we might use antiarrhythmic drugs. If they have a pulse but are unstable, low blood pressure, confused chest pain, they need immediate synchronized cardioversion.
An electrical shock.
Yes. But if they are pulseless with VTAC, that's a cardiac arrest, a life-threatening emergency. It demands immediate CPR and defibrillation. Because without effective pumping, the brain and organs aren't getting blood.
Defibrillation, the paddles.
Essentially, yes. An unsynchronized shock to try and reset the chaos. Even more dire is ventricular fibrillation, or VFib.
Worse than VTAC.
Yes.
Yeah.
In VFib, it's pure electrical chaos in the ventricles. They aren't contracting at all. They're just quivering randomly and uselessly. This means zero effective cardiac output. No blood is going anywhere.
So immediate collapse.
Immediate. The patient is unresponsive, not breathing, pulseless. This is one of the most urgent medical emergencies. Immediate, high-quality CPR, rapid defibrillation, and emergency medications like epinephrine are the only chance.
And the flat line.
Asystole, often called flatline. This is the complete absence of any detectable ventricular electrical activity. The heart has electrically and mechanically stopped.
No pulse, nothing.
No blood pressure, no pulse, no respirations.
Right.
It's another cardiac arrest emergency requiring immediate CPR and epinephrine. But, crucially, unlike VFib or pulseless VTAC, you cannot shock a systole because there's no underlying electrical activity to reset. Defibrillation only works if there's chaotic electrical energy to reorganize. With asystole, there's nothing to shock.
Wow. Okay, that clarifies a lot about how serious these rhythms can be. So when these really serious rhythm disturbances happen, it sounds terrifying, but you mentioned interventions. Powerful ways to potentially reset the heart's electrical system.
Yes, and what's truly fascinating here is the precision with which these life-saving interventions work. It's not just random shocking.
Right. You mentioned synchronized cardioversion.
Exactly. Synchronized cardioversion is a controlled electrical shock delivered to the heart. What makes it synchronized is absolutely key. The machine delivering the shock times it very carefully to coincide with a specific point in the heart's own electrical cycle, the R wave of the QRS complex.
Why is that timing so important?
To avoid delivering the shock during a vulnerable electrical period, like the T wave, which could actually trigger an even more dangerous rhythm, like VFib. So synchronization makes it safer.
Okay. And the goal is?
The goal is to essentially depolarize all the heart cells at once, interrupting the abnormal rapid electrical activity, and hopefully allowing the heart's natural pacemaker, the SA node, to regain control and restore a normal sinus rhythm.
And the patient is usually sedated for this.
Oh yes, typically. It can be uncomfortable or painful. It's used for rhythms like unstable SVT, unstable atrial fibrillation, or VTACH with a pulse where the patient is unstable.
Got it. What about long-term protection for people prone to these dangerous rhythms?
For individuals who have survived or at high risk for recurrent, life-threatening ventricular rhythms like VTAC or VFib, especially if not caused by a temporary issue like a heart attack, an implantable cardiac defibrillator or ICD might be placed.
An ICD, like a pacemaker.
Similar in that it's an implanted device but with a different primary function. An ICD is a small device, usually implanted under the skin near the collarbone with wires or leads that go into the heart.
And what does it do?
It constantly monitors the heart's rhythm. If it detects a dangerously fast ventricular rhythm like VTACH or VFib, it can automatically deliver a small internal electrical shock defibrillation to correct it and restore a normal rhythm.
Wow, so it's like having emergency paramedics inside you.
That's a pretty good analogy.
Mm-hmm.
Patients often describe the sensation of the shock as a brief jolt or a kick in the chest. It's startling, but life-saving.
What do patients with ICDs need to know?
Education is critical. They need to understand its purpose. It's there to stop life-threatening rhythms. They need to know how it works, what the shock feels like. There are some activity restrictions, primarily avoiding strong magnetic fields like from MRI machines or large industrial magnets, which could interfere with the device.
So no MRIs?
Definitely no MRIs unless the specific device is certified as MRI compatible, which is becoming more common but needs careful checking. They also need to carry an identification card, attend regular follow-up checks to ensure the device is working correctly, and know the warning signs to report, like frequent shocks.
It sounds like a very important safety net for those who need it.
It truly is a personal guardian for their heart rhythm.
Okay, let's shift gears a bit. Moving beyond the electrical rhythm, let's talk about heart failure. Now, this term can be confusing. It's not about the heart stopping, right?
That's a really important clarification. Heart failure doesn't mean the heart has stopped or is about to stop. It means the heart muscle simply isn't able to pump enough blood to keep up with the body's demands for oxygen and nutrients. It's become less efficient, a weakened pump.
And it's often a progressive struggle.
Yes, typically it's a chronic, progressive condition. This raises the question, why does the heart muscle weaken to this point?
What are the common causes?
Often it's the cumulative effect of chronic conditions that put excessive strain on the heart over years, leading to this sort of vicious cycle. Long-standing hypertension is a big one, making the heart constantly work harder to push blood against high resistance, eventually fatigues the muscle.
Makes sense.
Another major cause is a prior myocardial infarction, a heart attack. When part of the heart muscle dies from lack of oxygen, it gets replaced by scar tissue, and scar tissue doesn't pump. This weakens the overall function. Structural changes in the heart, like valve problems, can also contribute.
You often hear about left-sided versus right-sided heart failure. What's the difference?
Good question. It depends on which side of the heart is primarily failing.
Okay.
Left-sided heart failure, which used to be commonly called congestive heart failure, means the left side of the heart, particularly the left ventricle, the main pump to the body, isn't doing its job efficiently.
So blood backs up.
Exactly.
Okay.
Because the left side can't pump blood forward effectively, blood backs up into the pulmonary system, the lungs. This is why lung symptoms are so prominent in left-sided failure.
And there are different types of left-sided failure.
Yes, broadly two types based on the mechanism of failure. Systolic heart failure. Here, the heart muscle itself becomes thin, weak, and floppy. It struggles to contract forcefully. This means less blood is ejected with each beat, which is reflected in a reduced ejection fraction. The percentage of blood pumped out with each beat is low. Diastolic heart failure. In this type, the heart muscle often becomes stiff and thickened. The problem isn't necessarily the squeeze, but the relaxation. The stiff ventricle can't relax properly to fill with enough blood between beats. So even though it might pump out a good percentage of the blood it does receive, the ejection fraction might be preserved or even increased, it simply can't take in enough blood to begin with.
That's a crucial distinction. Stiff versus weak.
Very crucial. And a serious acute complication of left-sided heart failure is pulmonary edema. This is when fluid rapidly accumulates in the air sacs of the lungs because of that backup pressure. It feels like drowning.
What are the signs of that or worsening heart failure in general?
Key signs include a rapid heart rate, often over 100 at rest, maybe a new onset of AFib, blood pressure changes, either too low or very high, overwhelming fatigue, sometimes chest pain, angina, definitely worsening shortness of breath or cough, unexplained rapid weight gain from fluid retention, visible swelling in the neck veins, JVD, or peripheral edema in the legs and ankles. Changes in mental status, like confusion, can also occur if the brain isn't getting enough oxygen.
And right-sided failure.
Right-sided heart failure typically occurs when the right ventricle, which pumps blood to the lungs, cannot empty completely. This causes blood and pressure to back up in the venous system, the veins returning blood from the body.
So the swelling is more widespread.
Yes, leading to systemic venous congestion. You see more peripheral edema, swelling in the legs, ankles, feet, sometimes even the abdomen, ascites, or liver congestion.
What causes right-sided failure?
Interestingly, the most common cause of right-sided heart failure is actually left-sided heart failure.
Really? How's that work?
Because when the left side fails, pressure backs up into the lungs, pulmonary hypertension. This increased pressure in the lungs makes it much harder for the right ventricle to pump blood into the lungs. Eventually, the right side gets overworked and starts to fail too.
It's all connected.
Absolutely interconnected.
Yeah.
Management for heart failure, regardless of type, focuses on reducing the heart's workload, managing that excess fluid, and improving the heart's pumping ability or filling.
Medications play a big role.
A huge role. There's often a combination: ACE inhibitors, ARBs, beta blockers, diuretics to get rid of fluid, sometimes vasodilators or digoxin. The mnemonic, always administer drugs before a ventricle dies, helps remember key classes.
And lifestyle.
Critically important. Patients need strict education on limiting daily sodium intake, usually to 2-3 grams, and often limiting daily fluid intake to around 2 liters to prevent fluid overload. Monitoring daily weight is also key to catch fluid gain early. In advanced cases, options might include ventricular assist devices, VADs, or even heart transplantation.
It's a complex condition requiring constant management.
It really is.
Now, imagine the doors inside your heart, the valves not opening or closing properly. Maybe they get sticky and don't open fully, or maybe they're leaky and don't close tightly. That's essentially what happens with valvular heart disease.
That's a great analogy. And what's truly insightful here is understanding how these seemingly small mechanical issues with the valves can significantly stress the heart over time.
How so?
We have two main problems. Stenosis. This is when a valve becomes narrowed, stiff, or fused, so it doesn't open properly. The heart chamber before that valve has to pump much harder to force blood through that constricted opening. Think of trying to push water through a pinched hose. Regurgitation, or insufficiency. This is when a valve doesn't close tightly, allowing blood to leak backward through the valve when it should be closed. This means the heart has to repump that blood that just went the wrong way, plus the new blood coming in. It increases the volume workload.
So both scenarios make the heart work harder.
Exactly. Both stenosis and regurgitation increase the heart's workload, forcing to compensate. Over time, this chronic strain can lead to hypertrophy, thickening of the heart muscle, dilation, enlargement of the chambers, and eventually, if left unaddressed, can progress to heart failure.
How is valvular disease managed?
Management really depends on the specific valve affected, the severity of the problem, and the patient's symptoms and overall health. It can range from conservative approaches in milder cases like watchful waiting, managing symptoms, perhaps using medications to reduce the heart's workload or prevent complications like clots. Rest is often advised. Prophylactic antibiotics might be needed before certain dental or surgical procedures to prevent valve infection, endocarditis.
And if it's more severe?
Then more invasive procedures might be necessary. For stenosis, balloon valvuloplasty can sometimes be done, where a balloon catheter is threaded to the valve and inflated to stretch the narrowed opening.
Like angioplasty for valves?
Kind of, yeah. For more severe stenosis or significant regurgitation, surgical options are often required. This could involve repairing the existing valve, sometimes using techniques like ring annuloplasty to tighten a leaky valve, or it might involve replacing the faulty valve entirely with either a mechanical valve or a biological tissue valve.
Mechanical versus tissue.
Mechanical valves are very durable, but require lifelong anticoagulation, blood thinners, because clots can form on them easily. Tissue valves, often from pigs or cows, don't usually require lifelong anticoagulation, but may not last as long and might need replacement later on. There are also newer, less invasive techniques like transcatheter aortic valve replacement, TAVR, for certain patients with aortic stenosis, where a new valve is inserted via a catheter, avoiding open-heart surgery.
Lots of options tailored to the patient.
Precisely. The goal is always to relieve the strain on the heart, improve blood flow, manage symptoms, and prevent progression to heart failure.
Okay, let's talk about something incredibly common. High blood pressure, or hypertension. So many people live with this, but do we truly grasp what it means for the body beyond just seeing a high number on the cuff? It's often called the silent killer for a very unsettling reason.
It really is unsettling, and that term silent killer is accurate. Hypertension raises a couple of important questions. First, what's the difference between the kind of high blood pressure that just seems to develop on its own versus hypertension that's actually a symptom of some other underlying problem?
Right. Primary versus secondary.
Exactly. Most cases, maybe 90–95%, are essential or primary hypertension. This means there's no single identifiable underlying medical cause. It's likely a complex interplay of various factors.
Like lifestyle and genetics.
Precisely. Controllable factors like obesity, smoking, high-sodium diet, excessive alcohol, stress, lack of physical activity all play a role. And then there are uncontrollable factors like genetics, family history, age, and ethnicity.
And secondary hypertension.
Secondary hypertension is caused by another specific health problem. Things like chronic kidney disease, certain endocrine disorders like Cushing's syndrome or thyroid problems, or even narrowing of the arteries supplying the kidneys can directly cause blood pressure to rise. Treating the underlying cause can often resolve the secondary hypertension.
But why is it so dangerous, especially the silent part?
What makes essential hypertension, in particular, so insidious is that it often has absolutely no symptoms in its early or even moderately advanced stages. You can feel perfectly fine while it's quietly damaging your body.
Damaging what?
Over years, that persistently high pressure damages the inner lining of blood vessels throughout your body, making them stiffer and narrower, atherosclerosis. It forces your heart to work harder, leading to thickening, hypertrophy, and eventually heart failure. It damages the delicate blood vessels in your kidneys, potentially leading to kidney failure. It damages vessels in your eyes, risking vision loss or blindness. And it significantly increases your risk of stroke and heart attack.
All happening silently.
Often, yes. That's why regular blood pressure checks are so critical. When we assess blood pressure, we usually take at least 2 readings per visit, sometimes in both arms for comparison. We also check for orthostatic hypotension, that significant drop in BP, like 20 points systolic, when moving from lying down to sitting or standing, which can cause dizziness or falls.
Do symptoms ever appear?
Sometimes, if the pressure gets very high, people might experience headaches, often in the back of the head, facial flushing, dizziness, or occasional nosebleeds. But relying on symptoms is dangerous because damage is often occurring long before symptoms appear.
What about a hypertensive crisis?
That's the most alarming scenario. A hypertensive crisis is defined as a severely elevated blood pressure, typically above 180/30/20 mmHg. This is an immediate medical emergency because that extreme pressure can cause acute, rapid damage to target organs, the brain, stroke, heart attack, acute heart failure, kidneys, acute kidney injury, eyes.
What are the signs of a crisis?
Severe headache, intense dizziness or blurred vision, confusion, shortness of breath, chest pain, severe anxiety, sometimes nosebleeds.
How is it treated? Quickly drop the pressure.
Actually, no. While it's an emergency, the goal is not to drop the blood pressure extremely rapidly. Lowering it too fast can actually cause underperfusion of vital organs like the brain or heart, which have adapted to the higher pressure. The standard approach is to lower the mean arterial pressure, MAP, slowly and carefully, usually by no more than 25% within the first 2 to 6 hours, often using intravenous medications like labetalol in a controlled setting.
So controlled reduction is key.
Very key. For people diagnosed with hypertension in general, the main message is management through lifestyle changes. A heart-healthy diet, like the DHA's diet, significant sodium restriction, weight reduction if overweight, regular aerobic exercise, stress management techniques, moderating alcohol, and absolutely quitting smoking are the cornerstone.
And medications.
Medications are often necessary, yes, but lifestyle changes remain crucial, and one absolutely vital point for patients on antihypertensive meds. Always check your blood pressure before taking your dose, if possible, to make sure your pressure isn't already too low before you take a medication designed to lower it further. It helps prevent episodes of hypotension.
Good practical advice. Hypertension clearly needs lifelong attention.
Without a doubt.
Okay, it's not just the heart itself that's crucial for circulation. Your entire body is crisscrossed by this enormous network of blood vessels, miles and miles of highways and back roads. What happens when problems arise in that vast network out in the periphery, leading to peripheral vascular disease, or PVD?
That's a great way to think about the body's vascular network. And what's really fascinating and clinically very important when discussing PVD is the distinct difference in how problems manifest depending on whether they affect your arteries or your veins. They have very different structures and jobs.
Arteries versus veins. Tell us more.
Okay, so peripheral arterial disease, PAD, involves the arteries. These are the vessels carrying oxygen-rich blood away from your heart out to your limbs and organs. Arterial walls are generally thicker and more muscular because they have to withstand the high pressure generated by the heart's pumping.
High pressure, moving blood out.
Right. When these arteries, usually in the legs, become narrowed or blocked, most often due to atherosclerosis, plaque buildup, you get decreased perfusion. Simply put, not enough oxygenated blood gets through to the tissues downstream.
What does that feel like for the patient?
The classic symptom of PAD is intermittent claudication, cramping pain, or fatigue in the leg muscles, calves, thighs, buttocks, that occurs during exercise, like walking, and is relieved by rest. It happens because the muscle's oxygen demand increases with activity, but the narrowed arteries can't deliver enough blood.
Pain with walking, better with rest.
Exactly. Other signs include cool or cold feet, numbness or tingling, skin that looks pale or shiny, hair loss on the legs and feet, and toenails that might become thickened or brittle. Wounds or sores on the feet or toes especially tend to heal very poorly or not at all because of the poor blood supply.
What about the color of the legs?
The skin might look pale, especially when the leg is elevated. But when the leg is dangling down, dependent position, it might turn reddish or purplish, a sign called dependent rubor. And crucially, the pulses in the affected limb, like behind the knee or on the foot, are often weak or completely absent. In severe cases, it can lead to tissue death or gangrene.
Okay, so that's arterial disease. How does peripheral venous disease, PVD, differ?
Venous disease affects the veins. Veins are responsible for carrying deoxygenated blood back to the heart from the body. Their walls are generally thinner and more flexible than arteries because they operate under much lower pressure. They also have tiny one-way valves inside them to help blood flow against gravity, especially in the legs.
Low pressure, returning blood. Valves are key.
Yes. Problems in the veins often lead to issues with blood pooling or stasis because the return flow is impaired. This can happen if the valves are damaged, venous insufficiency, or if there's a blockage, like a clot, TVT.
So what are the symptoms of venous problems?
Venous disease symptoms tend to be different from PTA. Patients often describe a feeling of heaviness, aching, or throbbing pain in the legs, which might actually feel worse after standing or sitting for long periods and might improve with leg elevation. Swelling, edema in the legs and ankles is very common.
Swelling is a big one for veins.
Definitely. You might also see skin discoloration around the ankles, often a brownish, leathery appearance, due to chronic blood pooling and leakage of blood cells into the tissues. Varicose veins might be present.
What about pulses and skin temperature?
This is a key differentiator. In venous disease, peripheral pulses are usually present and normal, because the arterial supply isn't the primary problem. The skin is also typically warm.
And ulcers, do they happen with venous disease too?
Yes, but they look different. Venous ulcers typically occur around the ankle area, often the inner ankle, medial malleolus. They tend to be shallower than arterial ulcers, with irregular edges, and the ulcer bed often looks pink or red and might have drainage. They occur because the chronic swelling and poor circulation damages the skin.
So arterial ulcers are often on toes, pale, no pulse. Venous ulcers are often on ankles, pink red, pulses present.
That's a great summary of the classic differences. When assessing any vascular issue, it's crucial to compare both limbs, check circulation, sensation, movement, color, and pain very carefully, both when the limb is elevated and when it's dependent.
Very different pictures for arteries versus veins.
Absolutely. Understanding the difference is key to diagnosis and treatment.
Okay, let's talk about something that sounds inherently dangerous. Imagine a weak spot developing in one of your body's major pipelines, especially the aorta, your biggest artery, and that weak spot just keeps ballooning outwards. That's an aneurysm.
Yes, and dangerous is the right word, especially if they rupture. An aneurysm is technically defined as a permanent, localized dilation or outpouching of a blood vessel wall. For the aorta, it's generally diagnosed when a segment's diameter becomes at least 1.5 times, or sometimes double, its normal size.
What causes these weak spots to form?
The most common underlying cause, by far, is atherosclerosis, that same plaque buildup we talked about with CAD and PALD. The plaque damages and weakens the layers of the artery wall, making it susceptible to bulging under the constant pressure of blood flow. Other causes can include hypertension, which increases stress on the wall, genetic conditions affecting connective tissue, trauma, or infections, but atherosclerosis is the main driver.
Where do they usually occur?
They can happen in various arteries, but the most common and concerning location is the aorta. And within the aorta, they are most frequent in the abdominal section, below the kidneys. These are called abdominal aortic aneurysms, AAAs.
AAAs, are they usually symptomatic?
That's the scary part. Most AAAs are asymptomatic, especially when they're smaller. They're often discovered incidentally during imaging tests done for other reasons.
So they can grow silently?
Yes. And the risk of rupture increases significantly as the aneurysm gets larger, generally considered high risk when it exceeds 5.5 or 6 centimeters in diameter, particularly if the person also has uncontrolled hypertension.
Are there any signs if it's about to rupture?
Sometimes, yes. Signs of an impending rupture can include the new onset of severe, steady pain, often felt deep in the abdomen or lower back, which might radiate to the groin, buttocks, or legs. Some people might notice a pulsating sensation in their abdomen, like a heartbeat they can feel. If a doctor listens over the area, they might hear a bruit, that whooshing sound of turbulent blood flow.
And if it does rupture?
A ruptured AAA is a catastrophic, life-threatening emergency. It causes massive internal hemorrhaging into the abdominal cavity, leading rapidly to hypovolemic shock, severe blood loss, causing a drastic drop in blood pressure.
What would that look like?
The patient would likely experience sudden, excruciating abdominal or back pain, plummeting blood pressure, a rapid heart rate, pale and sweaty skin, diaphoresis, decreased level of consciousness or fainting, maybe decreased urine output, and loss of pulses in the legs below the level of the rupture. Survival rates are unfortunately low unless emergency surgery can be performed immediately.
Terrifying. What about aneurysms higher up in the chest?
Those are thoracic aortic aneurysms, TAAs. They're less common than AAAs, but it can also be very dangerous. Depending on their location and size in the chest, they might cause symptoms like persistent deep chest pain, back pain, shortness of breath, coughing, hoarseness, if pressing on the laryngeal nerve, or difficulty swallowing, dysphagia, if pressing on the esophagus. Rupture of a TAA is also a dire emergency.
How are aneurysms managed?
For smaller asymptomatic aneurysms, the approach is often watchful waiting with regular imaging, like ultrasound or CT scans, to monitor the size, combined with aggressive management of risk factors, especially strict blood pressure control. Lowering BP reduces stress on the weakened aortic wall. Smoking cessation is also critical.
And if it gets bigger or is symptomatic?
Then intervention is usually recommended to prevent rupture. The preferred method nowadays for many patients is an endovascular aneurysm repair, EVR for AAAs, or TVAR for TAs.
Endovascular.
You mean less invasive? Yes. Instead of a large open abdominal or chest surgery, EVR involves inserting a catheter, usually through arteries in the groin, and guiding a stent graft, a fabric tube supported by a metal mesh, stent up to the aneurysm. The graft is then deployed inside the aneurysm, effectively lining the aorta and excluding the weakened sac from blood flow and pressure.
Like relining the pipe from the inside.
Exactly. It's generally safer with a faster recovery than open surgery, although it requires lifelong surveillance imaging. Open surgical repair is still done, especially for complex aneurysms or if EVAR isn't suitable. Post-procedure, regardless of method, patients need careful monitoring, wound care if surgery was open, and typically restrictions on heavy lifting for a period to allow healing.
Aneurysms definitely sound like something you want to catch early.
Early detection and management are absolutely key.
Okay, this next condition truly lives up to its ominous-sounding name. Deep vein thrombosis, or DVT. It's a blood clot that forms quietly, deep inside a vein, usually in the leg, and it carries the potential for devastating consequences if it breaks loose and travels through the bloodstream.
It really is a condition that deserves respect and awareness. A DVT is a thrombus, or blood clot, that forms in one of the body's deep veins, most commonly in the calf, thigh, or pelvis. The clot itself can obstruct blood flow in that vein, causing local symptoms.
But the real danger is if it moves.
That's the biggest fear, yes. The clot, or a piece of it, can break off, embolize, and travel through the venous system back to the heart and get lodged in the pulmonary arteries in the lungs. This is called a pulmonary embolism, PE.
And a PE is serious.
Extremely serious. A large PE can block blood flow to the lungs, causing sudden shortness of breath, chest pain, collapse, and even sudden death. Shockingly, PE is considered the largest preventable cause of death among hospitalized patients, meaning it kills more people in hospitals than the conditions they were originally admitted for in some cases.
Preventable. How do we know who's at risk?
Understanding the risk factors is crucial for prevention. We often talk about Virchow's triad, named after the physician who described it. It outlines the 3 primary factors that contribute to DVT formation. Having one or more of these increases your risk significantly.
Virchow's triad, what are the 3 parts?
The triad consists of 1. Hypercoagulation. This means the blood itself has an increased tendency to clot. This can be due to genetic factors, certain cancers, inflammatory diseases like sepsis, dehydration, pregnancy, or the use of estrogen-containing medications like birth control pills. Major surgery or trauma also triggers a hypercoagulable state. 2. Vascular damage or endothelial injury. Damage to the inner lining of the blood vessel wall. This can be caused by direct trauma, surgery, especially orthopedic surgery on the legs or hips, inflammation of the vein, thrombophlebitis, atherosclerosis, or even the presence of intravenous catheters. 3. Circulatory stasis. Slow or stagnant blood flow in the veins. This is very common with prolonged immobility, like being on bed rest after surgery, long car or plane rides, paralysis, obesity, or conditions like heart failure, where circulation is sluggish. Varicose veins can also contribute to stasis.
So immobility after surgery is a big risk factor.
A huge one. That's why prevention strategies are so aggressively implemented in hospitals.
What are the symptoms of a DVT itself in the leg?
They can be subtle or even absent, but classic symptoms usually affect only one leg, unilateral. Look for tenderness or pain, especially in the calf, sometimes elicited by flexing the foot, though that's not always reliable, swelling or edema in the affected limb, skin that feels warm to the touch, and sometimes redness or discoloration. Often the affected leg will have a noticeably larger diameter compared to the healthy side.
So unilateral leg swelling and pain should raise suspicion.
Definitely. How do we prevent DVTs? Prevention is paramount, especially for high-risk individuals. Key strategies include early ambulation, getting patients moving as soon mobilizing as possible after surgery or illness. Mechanical devices, using things like graduated compression stockings, TED-hose, or sequential compression devices, SCDs, inflatable sleeves that wrap around the legs and periodically squeeze them to promote blood flow. Prophylactic anticoagulants, giving low doses of blood thinners like heparin or low molecular weight heparin to patients at high risk. Adequate hydration. Preventing dehydration helps keep blood less viscous. Leg exercises, simple ankle pumps and leg movements, even while sitting or lying down, can help.
And one really important, don't.
Absolutely crucial. Never massage an area where a DVT is suspected or known. Massaging could potentially dislodge the clot and send it traveling towards the lungs as a PE.
Good point. How are DVTs treated once they occur?
Treatment primarily involves anticoagulation. Medications like heparin, often given intravenously initially, requiring monitoring of PTT lab values, or low molecular weight heparin, given with injection, followed by oral anticoagulants like warfarin, which requires monitoring of PTINR labs, or newer direct oral anticoagulants, DOACs, are used.
What's the goal of the anticoagulants? Do they dissolve the clot?
Not directly. Anticoagulants don't actively dissolve the existing clot. Their main purpose is to prevent the current clot from getting bigger and to prevent new clots from forming, while the body's own natural clot-dissolving mechanisms gradually break down the existing thrombus over time. Treatment usually continues for at least 3 to 6 months, sometimes longer, depending on the cause and risk of recurrence.
What education do patients on anticoagulants need?
It's extensive. They need to understand the importance of taking the medication exactly as prescribed and never stopping it abruptly. They need to be aware of the increased risk of bleeding and take precautions using electric razors instead of blades, using soft toothbrushes, avoiding injuries and high-risk activities. They must know the signs of bleeding to report immediately, like unusual bruising, nosebleeds, blood in urine or stool, severe headache. And they need regular lab monitoring if they're on warfarin.
DVT and PE, definitely serious business requiring vigilance.
Absolutely. Prevention and prompt recognition are key.
Okay, let's dive into a topic that encompasses several of the heart issues we've touched on. Acute coronary syndromes, or ACS. This often starts with the underlying problem of coronary artery disease.
Yeah,
Yeah.
exactly. If we connect this back, CAD is really the foundation upon which most acute coronary events occur. It's that process of atherosclerosis plaque buildup happening specifically within the coronary arteries, the vessels that supply oxygenated blood to the heart muscle itself.
Like clogging the pipes that feed the heart engine.
Perfect analogy. This plaque buildup narrows the arteries, restricting blood flow.
What drives CAD? Same risk factors we've discussed.
Largely, yes. The major culprits are high cholesterol, hyperlipidemia, hypertension, smoking, a huge factor, diabetes, which accelerates atherosclerosis, obesity, a sedentary lifestyle, and of course, family history and increasing age.
Can you have CAD and not know it?
Absolutely. CAD often develops silently over decades. Some people might be completely asymptomatic. Others might start experiencing angina, that chest pain or discomfort typically brought on by exertion, when the heart muscle's oxygen demand exceeds what the narrowed arteries can supply. Other subtle signs could be shortness of breath, dyspnea, or unusual fatigue.
And if it progresses,
If CAD progresses or a plaque becomes unstable, it can lead to the more serious acute coronary syndromes, including unstable angina and myocardial infarction, heart attack. It's also the leading cause of heart failure and can trigger dangerous arrhythmias.
how is CAD managed?
Management focuses on two main goals: slowing or potentially reversing the plaque buildup and preventing acute events. Aggressive lifestyle modification is paramount. Smoking cessation is number one. Adopting a heart-healthy diet low in saturated fats and sodium, regular exercise, weight management.
And medications.
Medications are crucial. Statins to lower cholesterol, aspirin or other antiplatelet drugs to prevent clot formation, beta blockers to reduce the heart's workload and oxygen demand, ACE inhibitors to manage blood pressure and protect the heart, and sometimes nitrates to relieve angina.
What if lifestyle and meds aren't enough?
Then procedures to restore blood flow might be needed, like percutaneous coronary intervention, PCI angioplasty, and stenting to open blocked arteries, or coronary artery bypass graft CADG surgery to reroute blood flow around blockages.
So CAD is the underlying chronic issue.
It's the stage upon which the acute dramas often play out.
Let's talk more about angina. You mentioned it's that warning sign chest pain signaling the heart isn't getting enough oxygen. But you also hinted there's a critical difference between predictable angina and something much more serious.
Yes, this distinction is absolutely vital. It raises the question, why is unstable angina considered such a red flag, demanding immediate medical attention?
Okay, first, what's stable angina?
Stable angina is characterized by its predictability. It's chest discomfort or pain that occurs under specific circumstances that increase the heart's oxygen demand, most commonly physical exertion or sometimes emotional stress.
Like climbing stairs or getting upset.
Exactly. The key features are that it's usually relieved relatively quickly, within minutes, typically less than 15, by either resting or taking nitroglycerin medication. The pattern is consistent over time for that individual. It signals underlying CAD, but the plaque causing the narrowing is generally stable.
Okay, predictable, relieved by rest or nitro. What makes angina unstable?
Unstable angina is far more concerning because it signifies a change, an instability, in the underlying plaque. It represents an acute coronary syndrome. Unstable angina has one or more of these characteristics. 1, it's new-onset angina that's severe or limits activity. 2, it's existing stable angina that has become more frequent, more severe, lasts longer, or is triggered by less exertion than before. 3, crucially, occurs at rest, without any obvious trigger.
Pain even without exertion.
Right. Furthermore, unstable angina may last longer than 15 minutes, and it often isn't fully or promptly relieved by rest or nitroglycerin.
What's happening inside the artery during unstable angina?
It usually indicates that an atherosclerotic plaque has ruptured or eroded, leading to the formation of a blood clot that is causing a partial or intermittent blockage of the coronary artery. Blood flow is severely compromised, but not yet totally cut off long enough to cause significant heart muscle death.
So no heart muscle death yet.
That's the critical point. In unstable angina, cardiac biomarkers like troponin will typically be normal. There hasn't been significant myocardial necrosis, cell death. However, it's an extremely high-risk situation.
Why high risk?
Because that unstable plaque and partial clot can progress very quickly to a complete blockage, resulting in a full-blown myocardial infarction, heart attack. Unstable angina is considered an emergency, requiring immediate evaluation and treatment to prevent an MI.
So stable angina is a warning sign of chronic CAD, but unstable angina is an acute emergency signaling an impending or evolving heart attack.
Precisely. Recognizing that difference is critical. Any new worsening or rest angina needs immediate medical attention. 9/11.
Got it. That leads us directly to the big one, the event people commonly call a heart attack. This is myocardial infarction, or MI, where actual permanent damage occurs to the heart muscle itself.
Yes, the MI. And what's truly fascinating, and frankly terrifying from a physiological standpoint, is the precise mechanism. An MI occurs when blood flow through one of the coronary arteries is completely or almost completely blocked for a prolonged period.
A total blockage.
Usually, yes. Most often, this happens when an unstable atherosclerotic plaque ruptures, triggering the rapid formation of a thrombus, a blood clot, right at the site of rupture, which then totally occludes the artery.
And the consequence.
Without oxygenated blood flow downstream from the blockage, the heart muscle cells supplied by that artery begin to suffer injury. And if the blockage isn't relieved quickly, they start to die. There's a myocardial necrosis, permanent damage. This is why immediate action is absolutely critical. There's a common saying in cardiology, time is muscle. The longer the artery stays blocked, the more heart muscle dies.
What does an MI feel like? Is it always crushing chest pain?
Crushing, squeezing, heavy chest pain or pressure, often described as feeling like an elephant sitting on the chest, is the classic symptom. The pain frequently radiates commonly to the left arm, but also potentially to the jaw, neck, back, or even the stomach area.
And unlike unstable angina.
Critically, unlike even unstable angina, the pain of an MI is typically not relieved by rest or nitroglycerin. It's persistent. People often experience other symptoms too. Profound shortness of breath, dyspnea, cold sweats, diaphoresis, nausea or vomiting, extreme fatigue or weakness, dizziness, and sometimes a frightening feeling of impending doom.
That sounds terrifying.
It is. It's important to note, though, that some people, particularly women, older adults, and individuals with diabetes, may experience atypical symptoms like unusual fatigue, indigestion-like pain, or just shortness of breath without the classic chest pain. This would unfortunately lead to delays in seeking treatment.
How is an MI confirmed?
Diagnosis relies on a combination of the clinical presentation, symptoms, characteristic changes on the ECG, and elevated cardiac biomarkers in the blood.
ECG changes.
Yes. An MI can cause specific ECG patterns. A STEMI, ST segment elevation myocardial infarction, shows a characteristic elevation of the ST segment on the ECG, indicating a full-thickness injury to the heart muscle, usually caused by a complete blockage. This requires immediate reperfusion therapy. An NSTEMI, non-ST segment elevation MI, might show ST depression or T-wave inversion, indicating partial thickness damage, usually from a severe but not total blockage. While still an MI because biomarkers are elevated, the immediate treatment strategy might differ slightly from STEMI.
And the biomarkers, troponin again.
Yes, troponin levels will be elevated in both STEMI and NSTEMI, confirming that heart muscle cell death has occurred. Creatine kinase MBE, CKMB, is another biomarker that might be checked.
What's the immediate management in the ER?
If an MI is suspected, immediate treatment often follows the MONA acronym, though not always in that specific order anymore. Morphine. For severe pain relief, also reduces anxiety and heart workload. Oxygen, usually given if oxygen saturation is low, to improve oxygen supply to the struggling heart muscle. Nitroglycerin, sublingual or bead AV, to help dilate coronary arteries and reduce preload afterload. Aspirin. A chewable dose is given immediately to inhibit platelet aggregation and help prevent the clot from worsening. Other antiplatelet drugs might also be given.
MONA. Okay, and then the focus shifts to opening the blockage.
Absolutely. The absolute priority after initial stabilization is reperfusion therapy, restoring blood flow to the affected heart muscle as quickly as possible to salvage tissue and limit the extent of the damage.
So once that initial MONA response is underway in an emergency setting for a suspected heart attack, especially a STEMI, you said the primary goal is reperfusion, getting that blocked artery open fast. What are the main ways that's done?
Right, speed is absolutely critical. The two main strategies for reperfusion are percutaneous coronary intervention, PCI, and thrombolytic therapy.
PCI, is that angioplasty and stenting?
Exactly. PCI is generally the preferred treatment for STEMI if it can be performed quickly, ideally within 90 minutes of the patient's first medical contact or arrival at a capable hospital, door-to-balloon time.
How does PCI work?
It's an invasive but non-surgical procedure performed in a cardiac catheterization lab, cath lab. A cardiologist guides a thin, flexible tube, catheter, with a balloon on its tip through an artery, usually in the wrist, radial artery, or groin, femoral artery, up to the site of the blockage in the coronary artery.
Finds the blockage.
Yes. Once positioned, the balloon is inflated, compressing the plaque and thrombus against the artery wall to open up the vessel, angioplasty. In almost all cases, a stent, a small, expandable metal mesh tube, is then deployed at the site to act like a scaffold, keeping the artery propped open long-term. Some stents are coated with medication, drug-eluting stents, to help prevent re-narrowing. Sometimes devices are used to suction out the clot first.
Wow. Direct mechanical fix.
It's incredibly effective when done promptly. What about after PCI? What's the care like? Post-PCI care is crucial. Patients require dual antiplatelet therapy, DAPT, usually aspirin, plus another potent antiplatelet drug like clopidogrel, prasugrel, or ticagrelor for an extended period, often a year or more, to prevent clots from forming on the new stent, which is a serious risk, stent thrombosis. They'll need bed rest for a few hours, especially if the femoral artery was used, with the head of the bed kept relatively flat initially. We monitor the insertion site closely for bleeding or hematoma formation.
Checking pulses, too.
Absolutely. We frequently check pulses, skin color, and temperature in the limb, used for access to ensure good perfusion hasn't been compromised. We also monitor closely for any return of chest pain or new ECG changes like ST elevation, which could indicate an acute problem with the stent.
Okay, so PCI is preferred if available quickly. What if it's not?
If PCI cannot be performed within the recommended time frame, for example, the patient is at a hospital without a cath lab or transport times are too long, then thrombolytic therapy, also called fibrinolytic therapy, might be used.
Clot-busting drugs.
Exactly. These are powerful medications like Alteplase, TPA, or tenecteplase, TNKZ, that are given intravenously to actively dissolve the blood clot that's blocking the coronary artery. The goal is to administer these ideally within 30 minutes of arrival at the hospital, door-to-needle time.
Are they as effective as PCI?
They can be life-saving, but generally PCI is considered more effective at fully restoring normal blood flow and has a lower risk of major bleeding complications compared to thrombolytics. Thrombolytics also have more contraindications, reasons they can't be used, such as recent surgery, stroke, or active bleeding. Often, even if thrombolytics are given, the patient may still be transferred later for PCI.
So PCI are thrombolytics for the acute phase. What about surgery? CABG.
Coronary artery bypass graft, CABG surgery, often pronounced cabbage, is usually not an emergency treatment for an acute MI itself. PCI is much faster. However, CABG is a major surgical option for patients with extensive CABG, typically those with blockages in multiple coronary arteries or blockage in the critical left main coronary artery, or those who aren't suitable candidates for PCI, or sometimes after an MI if there's still significant disease needing treatment.
How does CABG work?
It's open heart surgery. The surgeon takes blood vessel grafts, often the saphenous vein from the leg, or arteries like the internal mammary artery from the chest wall, and uses them to create new pathways, bypassing the blocked segments of the coronary arteries. Blood flow is rerouted around the blockages directly to the heart muscle downstream.
Creating detours for the blood flow.
Precisely. What kind of preparation and recovery does that involve? It's major surgery. It is. Preoperatively, patients need thorough evaluation and teaching. There'll be NPO, nothing by mouth, before surgery, sign consent forms, have medications adjusted. They often shower with a special antiseptic wash, like 4% CHG. We teach them how crucial it is to splint their chest incision with a pillow when coughing or deep breathing afterwards to manage pain and prevent complications. Using an incentive spirometer to keep lungs clear is vital. Arm and leg exercises are taught to prevent blood clots. 40 antibiotics are given prophylactically.
And post-op, what's that like?
Post-op, Patients go to the intensive care unit, ICU initially. They'll likely be on a ventilator for a short time, require significant pain management, have several chest tubes in place to drain fluid from around the heart and lungs, a Foley catheter to monitor urine output. Often, temporary pacemaker wires are placed during surgery in case of rhythm problems post-op.
Sounds intense.
It is. But early ambulation, getting the patient out of bed and walking, sometimes as early as the day after surgery, is incredibly important to prevent complications like pneumonia and blood clots. Recovery involves gradually increasing activity, cardiac rehab, and managing potential complications.
What are the main complications to watch for after CABG?
There are several potential issues. Dysrhythmias, especially atrial fibrillation, are common. Cardiac tamponade, bleeding into the sac around the heart, compressing it, is a surgical emergency. Fluid and electrolyte imbalances need careful monitoring, bleeding from graft sites or the incision. Blood pressure fluctuations, both high and low. Hypothermia initially. Respiratory issues are a big concern, hence the focus on deep breathing, coughing, incentive spirometry. We constantly assess their pulmonary status. Neurologic changes like stroke or confusion can occur. Kidney function needs monitoring. And infection is always a risk, particularly mediastinitis, a serious infection of the sternum, breastbone, and surrounding tissues. Signs like fever developing after the first few days post-op, redness or bogginess around the sternal incision, increased drainage, or a high white blood cell count are red flags for mediastinitis.
A lot to manage after such a big surgery.
Definitely requires vigilant, skilled post-operative care.
Okay, shifting focus slightly, but staying connected. Ultimately, all the heart's intricate work, all that pumping and electrical activity, comes down to one fundamental goal: getting enough oxygen to every single cell and tissue in your body. Sometimes, despite the heart and lungs doing their best, the body needs a little extra help with that vital process. That brings us to oxygen therapy.
Right. Oxygen is essential for life, for cellular metabolism. And this raises an important question. What's the difference between having low oxygen levels in your blood versus low oxygen actually reaching your tissues? And how do we deliver supplemental oxygen safely and effectively when it's needed?
Good distinction. Blood versus tissues.
We use the term hypoxemia to specifically refer to low oxygen levels in the arterial blood. We measure this with things like pulse oximetry, SpO2, or arterial blood gas, PO2 tests. Hypoxia, on the other hand, is a broader term, meaning a deficiency of oxygen reaching the tissues themselves, which is the ultimate problem we're trying to prevent or treat. Hypoxemia is a common cause of hypoxia, but you can also have hypoxia if circulation is poor or cells can't utilize oxygen properly.
So oxygen therapy aims to fix hypoxemia to prevent hypoxia.
Primarily, yes. The main purpose of oxygen therapy is to increase the oxygen concentration the patient is breathing, which in turn increases the amount of oxygen carried by the blood, both bound to hemoglobin and dissolved in plasma, hopefully relieving hypoxemia and ensuring adequate oxygen delivery to the tissues.
How is oxygen delivered? I see people with nasal bronchs.
There are various delivery systems chosen based on how much oxygen the patient needs, how precise the delivery needs to be, and the patient's condition. We broadly categorize them into low-flow and high-flow systems. Low-flow systems deliver oxygen, but the exact percentage of oxygen the patient actually breathes, FiO2, can vary depending on their own breathing pattern, because room air gets mixed in. Examples include nasal cannula, those common 2 prongs in the nose, delivers lower concentrations, typically 1 to 6 liters per minute, providing about 24–44% oxygen, comfortable for long-term use. Simple face mask, covers nose and mouth, needs at least 5 liters min flow to flush out exhaled CO2. Delivers about 40–60% oxygen. Partial rebreather mask. Has a reservoir bag attached. Allows the patient to rebreathe some exhaled air along with fresh oxygen. Delivers 60–75% oxygen at flows of 6–11 liters min. Non-rebreather mask. Similar bag, but has one-way valves to prevent rebreathing exhaled air. This delivers the highest possible oxygen concentration via a mask, often approaching 80–95%, used for critically ill or unstable patients needing maximum oxygen short-term.
And high-flow systems.
High-flow systems are designed to deliver a precise oxygen concentration, FiO2, regardless of the patient's breathing pattern, because they provide oxygen flow rates that meet or exceed the patient's own inspiratory demand. Examples include high-flow nasal cannula, HFNC, delivers warm to humidified oxygen at very high flow rates, like 30–60 liters min or more, via special nasal prongs. More comfortable than tight masks for some. Venturi mask, or Venti mask, this is considered the most accurate oxygen delivery method among masks. It has special color-coded adapters that precisely mix a fixed amount of oxygen with a fixed amount of room air, allowing delivery of very specific FiO2 levels, for example, 24%, 28%, 35%, 40%, 50%. often used for patients with COPD who need careful oxygen titration.
Accurate delivery sounds important.
It can be, especially in conditions where too much oxygen could be harmful, like in some COPD patients.
Are there dangers to using oxygen? It seems so basic.
While life-saving, oxygen therapy isn't without potential hazards. Combustion. Oxygen itself doesn't burn, but it vigorously supports combustion. A small spark can become a big fire in an oxygen-enriched environment. So strict no-smoking policies, ensuring electrical equipment is safe, and using oxygen use signs are absolutely critical safety measures. Oxygen toxicity. Breathing very high concentrations of oxygen, typically 50–60%, for prolonged periods, more than 24 to 48 hours, can actually damage the lungs, causing inflammation and reducing function. We always aim to use the lowest FiO2 needed to maintain adequate oxygen saturation. Drying of mucous membranes. Oxygen, especially when delivered without humidification, can be very drying to the nasal passages and airways, causing discomfort, irritation, and potential nosebleeds. Humidification is often added, especially at higher flow rates. Infection. Oxygen equipment like humidifiers and nebulizers can become contaminated with bacteria if not cleaned properly, posing an infection risk.
So it's a medication that needs careful handling.
Absolutely. Treated with respect, just like any other medical therapy.
We've touched on this numerous times throughout our discussion, how so many cardiovascular and respiratory conditions, from heart attacks and PA to COPD and lung infections, are intrinsically linked to smoking. This really feels like the place where it all comes together, a critical intervention that directly impacts both your heart and lungs.
You're absolutely right. If there's one single modifiable risk factor that has a profoundly negative impact across both the cardiovascular and respiratory systems, it's smoking. Quitting smoking is arguably the single most impactful health intervention a person can make.
It seems obvious, but quitting is notoriously hard. How does healthcare approach this?
Recognizing how critical yet difficult it is, healthcare takes a very structured, evidence-based approach to help individuals quit. It's not just casual advice anymore, it's considered a standard part of care. A widely adopted framework is known as the 5 A's.
The 5 A's, what are they?
It's a simple strategy for clinicians. 1. Ask. Ask every patient about their tobacco use status at every healthcare encounter. Make it routine. 2. Advise. In a clear, strong, and personalized manner, advise every tobacco user to quit. Link it directly to their current health concerns or goals. 3. Assess. Assess the patient's willingness and readiness to make a quit attempt at this time. Are they thinking about it? Ready to set a date? Not ready yet. Meeting them where they are is key. 4. Assist. For patients willing to try quitting, assist them in their quit attempt. This involves helping them set a quit date, providing practical counseling on problem solving and skills training, discussing challenges, arranging social support, and importantly, recommending and prescribing pharmacotherapy. 5. Arrange. Arrange for follow-up contact either in person or by phone shortly after the quit date and then again later to provide ongoing support, monitor progress, and address any relapses.
What about the medications you mentioned?
Pharmacotherapy can significantly increase the chances of successfully quitting. This includes various forms of nicotine replacement therapy, NRT, like patches, gum, lozenges, inhalers, and nasal sprays, which help manage withdrawal symptoms by providing nicotine without the harmful toxins of smoke. There are also prescription medications like bupropion, Zybin, and varenicline, Chantix, that work on brain chemistry to reduce cravings and withdrawal. Combining counseling with medication is generally the most effective approach.
So it's a multifaceted approach, recognizing it's an addiction.
Exactly. It treats nicotine dependence as a chronic relapsing condition that often requires repeated intervention and long-term support. But the benefits of quitting start almost immediately. Blood pressure drops, heart rate slows, carbon monoxide levels decrease within hours. And the long-term benefits for reducing risk of heart attack, stroke, lung cancer, COPD, and numerous other diseases are immense. It's never too late to quit.
A powerful message. Quitting smoking is fundamental to heart and lung health.
Absolutely fundamental.
Okay, let's transition fully into the respiratory system now. From the seasonal flu, which knocks so many people down each year, to more serious, persistent infections, your respiratory system is constantly on the front lines, battling invaders. It's like your body's primary air filter and defense system against airborne threats.
That's a great way to put it. And if we connect this to the bigger picture, these infectious respiratory diseases really underscore the immense importance of public health measures, things like vaccination campaigns, early detection and reporting, isolation protocols. They're all crucial not just for protecting individuals, but for preventing widespread community transmission.
Let's start with the familiar one, influenza or the flu.
Right. Influenza is a highly contagious viral infection that primarily attacks the respiratory system, nose, throat, lungs. It's notorious for causing seasonal epidemics, usually in the fall and winter,
How does it spread so easily?
mainly through droplets produced when infected people cough, sneeze, or talk. These droplets can land in the mouths or noses of people nearby, or possibly be inhaled into the lungs. Less often, a person might get flu by touching a surface or object that has flu virus on it, and then touching their own mouth, nose, or eyes.
What are the typical symptoms? How is it different from a cold?
Flu symptoms often come on suddenly and tend to be more severe than the common cold. Classic signs include high fever, chills, severe headache, significant muscle aches, myalgia, extreme fatigue and weakness, often a dry cough. While colds usually involve more sneezing and runny, stuffy nose, flu hits you harder systemically.
When are people contagious?
This is important for prevention. Adults can typically spread the flu starting about 24 hours before their symptoms even begin, and they remain contagious for up to 5 to 7 days after becoming sick. Kids can be contagious for even longer.
Wow, spreading it before you even know you have it.
Exactly. That's why prevention is key. What are the best ways to prevent flu? Number 1 is hand washing, frequent and thorough. Number 2 is the annual flu vaccination. While not 100% effective, the flu shot significantly reduces the risk of getting the flu and, importantly, reduces the severity of illness and risk of complications like pneumonia if you do get sick. Checking for contraindications like a history of Guillain-Barré syndrome after a previous flu shot is important. Simple things like covering your cough or sneeze, ideally into your upper arm elbow, not your hands, also help.
And flu can sometimes cause global pandemics, right?
Yes, historically, novel influenza strains have caused devastating pandemics. This highlights why global surveillance, early recognition of new strains, and potentially quarantine measures are so critical from a public health perspective.
Indeed, COVID-19, caused by the SARS-CoV-2 virus, primarily presents as a respiratory illness, though it can affect many other organ systems.
What were the key things to assess for COVID? Assessment involved looking for common upper respiratory symptoms like cough, sore throat, fever, chills, shortness of breath or difficulty breathing, fatigue, muscle aches, headache. But COVID also had some more distinctive potential symptoms, particularly the sudden loss of taste, ageusia or smell, anosmia. Asking about vaccination status and recent exposure history became crucial. The gold standard for diagnosis was typically the RT-PCR assay, usually from a nasal or throat swab, which detects the virus's genetic material. Rapid antigen tests were also widely used for quicker screening.
Management focused on.
Management really depended on severity. For mild cases, it was often home isolation to prevent transmission, rest, hydration, and symptom management. For more severe cases requiring hospitalization, treatment focused on maintaining adequate gas exchange, often requiring supplemental oxygen or mechanical ventilation, using antiviral medications like Paxlovid or remdesivir in certain patients, managing inflammation with corticosteroids, preventing blood clots, and supporting recovery. Vaccination remains the cornerstone of preventing severe disease and hospitalization.
Okay, another serious lung infection. Tuberculosis, or TB, caused by bacteria.
Yes, TB is caused by a specific bacterium called Mycobacterium tuberculosis. Unlike flu or COVID, it's bacterial, not viral.
How is TB spread?
Primarily through aerosolization, meaning it's airborne. When a person with active pulmonary TB coughs, laughs, sneezes, whistles, or even sings, they release tiny infectious droplets containing the bacteria into the air, which can then be inhaled by others. It usually requires prolonged close contact to get infected.
Does everyone infected get sick?
No. Many people who get infected develop latent TB infection, where the bacteria remain dormant in their body, walled off by the immune system, causing no symptoms and not being contagious. However, the bacteria can reactivate later in life, especially if the person's immune system becomes weakened. This reactivation is called secondary TB. It's more common in individuals with chronic diseases, HIV, malnutrition, or those on immunosuppressive drugs.
What are the symptoms of active TB disease?
Symptoms often develop gradually and can be quite vague initially. They commonly include persistent fatigue and lethargy, nausea, loss of appetite, anorexia, and unexplained weight loss, irregular menses in women, low-grade fevers, especially in the afternoon, evening, and night sweats. A persistent cough is characteristic, initially dry, but later often producing sputum that may be streaked with blood, hemoptysis. Dull, aching chest pain can also occur.
How is it diagnosed?
Diagnosis involves several components: assessing symptoms and risk factors, a chest x-ray, which often shows characteristic changes in the upper lobes of the lungs, and crucially, identifying the bacteria itself through sputum culture. Sputum tests, smear microscopy and culture, are definitive. There are also tests for infection, latent or active, like the tuberculin skin test, TST, also known as the PPD test, where a small amount of tuberculin protein is injected under the skin and the reaction is measured 72 hours later. Blood tests like the quantiferon TB Gold assay are also used.
Treatment sounds serious for TB.
It is. Treating active TB requires a combination of multiple antibiotic medications taken for an extended period, typically at least 6 months, sometimes up to 2 years or longer for drug-resistant strains. Strict adherence to the full course of medication is absolutely critical.
Why multiple drugs, and for so long?
To prevent the bacteria from developing resistance to the medications. If treatment isn't completed properly, drug-resistant TB can emerge, which is much harder and more expensive to treat. Because adherence can be challenging, directly observed therapy, DOT, is often recommended, where a healthcare worker physically watches the patient swallow each dose of medication.
What are some key medications?
The core first-line drugs often include INH, isoniazid, very effective but needs to be taken on an empty stomach. Patients should avoid antacids and alcohol. It can deplete vitamin B6, so supplementation is usually recommended to prevent nerve damage. Rifampin, or rifampins, another cornerstone drug. A notable side effect is that it can cause orange-red staining of bodily fluids like urine, sweat, tears. It can even permanently stain soft contact lenses.
Orange urine. Good to know.
Definitely something to warn patients about. Other drugs like pyrazinamide and ethambutol are also commonly used in the initial phase. A major concern with several TB drugs, such as INH, rifampin, and pyrazinamide, is potential liver toxicity.
So liver function needs monitoring.
Yes. Patients must be educated to avoid alcohol throughout treatment and to immediately report any signs of liver problems like persistent nausea, vomiting, abdominal pain, dark urine, jaundice, yellowing of skin or eyes, or increased bruising, bleeding.
TB sounds like a major commitment to treat properly.
It absolutely is, requiring close monitoring and patient dedication.
Now for something truly terrifying, though thankfully rare, inhalation anthrax. You mentioned this can occur naturally, but also as a potential bioterrorism agent.
Yes, Bacillus anthracis, the bacterium that causes anthrax, exists naturally in soil. While skin, cutaneous anthrax, is the most common natural form from handling infected animals, inhalation anthrax occurs when anthrax spores are breathed into the lungs. This form is particularly concerning as a potential bioterrorism weapon because the spores can be dispersed easily and the resulting lung infection is incredibly deadly if not treated very early.
How deadly?
If the lung infection from inhaled spores progresses to the second stage and is left untreated, the fatality rate approaches 100%.
Wow. What are the stages?
Inhalation anthrax typically progresses in 2 distinct stages. 1. Prodromal stage. This initial stage often mimics the flu or a common cold. Symptoms can include fever, fatigue, muscle aches, mild chest discomfort, and a dry cough. This stage might last a couple of days. The key problem is that it's nonspecific, making early diagnosis difficult. 2. Fulminant stage. After perhaps a brief period of apparent improvement, there's a sudden onset of severe illness. This stage is characterized by abrupt respiratory distress, severe shortness of breath, stridor, a high-pitched breathing sound, chest pain, patients might vomit blood, they become sweaty, diaphoretic, turn blue, cyanotic due to lack of oxygen, and can rapidly progress to septic shock and hemorrhagic meningitis, bleeding around the brain. Death often occurs within 24 to 36 hours of a fulminant stage onset if treatment hasn't begun.
That's incredibly rapid and severe, so treatment has to start early.
Absolutely critical. Treatment must begin during the prodromal stage to be effective. Once the fulminant stage begins, the bacterial toxins have caused too much damage, and mortality is extremely high even with treatment.
What's the treatment?
Aggressive, prolonged courses of antibiotics are required. Typically, ciprofloxacin or doxycycline are first-line choices. Treatment often lasts for 60 days because the spores can linger in the body. For severe symptoms or suspected bioterrorism exposure, specific anthrax antitoxins might also be administered to neutralize the bacterial toxins. Public health response in a bioterrorism scenario would involve identifying exposed individuals and providing prophylactic antibiotics.
A truly frightening potential threat.
It underscores the importance of public health preparedness for such events.
Okay, let's wrap up the infections with a very common one. Pneumonia. You described it simply as excess fluid in the lungs.
Yes. At its core, pneumonia is an infection that causes inflammation in the air sacs, alveoli, of one or both lungs. These air sacs may fill with fluid or pus, purulent material, which interferes with the lung's primary job, Gas exchange getting oxygen into the blood and carbon dioxide out.
And that reduced gas exchange leads to problems.
Exactly. It can lead directly to hypoxemia, low blood oxygen levels. If severe or untreated, pneumonia can progress to respiratory failure, sepsis, a life-threatening bloodstream infection, lung abscesses, and unfortunately can be fatal, especially in vulnerable populations.
How is pneumonia categorized?
We often categorize it based on where the infection was acquired, as this can give clues about the likely causative germs and guide treatment. Community-acquired pneumonia, CAP. Contracted outside of a hospital or long-term care facility. Hospital-acquired pneumonia, HAP, develops 48 hours or more after hospital admission. Ventilator-associated pneumonia, VAP, develops more than 72 hours after endotracheal intubation and mechanical ventilation. HAP and VAP are often caused by more drug-resistant bacteria. Ventilator-associated pneumonia, VAP. There's also aspiration pneumonia caused by inhaling food, drink, vomit, or saliva into the lungs.
Who is most at risk for getting pneumonia?
Certain groups are definitely more vulnerable. Older adults, over 65, are at higher risk. Residents of nursing homes or hospitalized patients. Individuals with chronic lung diseases like COPD or asthma. People with weakened immune systems due to HIV, chemotherapy, long-term steroid use. Patients with neurological problems or difficulty swallowing, dysphagia, are at high risk for aspiration pneumonia. And anyone on mechanical ventilation is at risk for VAP. Smokers are also at increased risk.
What are the typical symptoms?
Symptoms can vary from mild to severe. Common signs include cough, which may produce phlegm that can be greenish, yellow, or even bloody rust-colored, fever, shaking chills, shortness of breath, dyspnea, or rapid, shallow breathing, tachypnea, chest pain that worsens with deep breathing or coughing, pleuritic chest pain, fatigue, and sometimes confusion, especially in older adults. If the pneumonia is severe enough to cause significant hypoxia affecting the heart, dysrhythmias can also occur.
Prevention sounds important here too.
Very important. Key prevention strategies include vaccination. The pneumococcal vaccine is recommended for all adults over 65, and for younger adults with certain chronic illnesses or risk factors. Annual flu shots and COVID vaccines are also crucial, as pneumonia is a common complication of these viral infections. Lifestyle advice. Simple things like frequent hand washing, avoiding crowded places during peak flu season, practicing good respiratory hygiene, coughing into elbow. For hospitalized or immobile patients, encouraging regular turning, deep breathing exercises, use of incentive spirometers, and early ambulation helps keep lungs clear. Ensuring respiratory equipment, like CPAP machines, is kept clean. Avoiding pollutants and definitely stopping smoking. Maintaining good oral hygiene, eating a healthy diet and staying hydrated, drinking plenty of fluids like 3 liters daily unless restricted, helps thin secretions.
Simple habits can make a big difference.
We really can in preventing respiratory infections like pneumonia.
Wow. What an incredible deep dive we've taken today. We've journeyed from the really precise anatomical details of your beating heart
The chambers and valves.
to the intricate electrical impulses that actually power it. We explored the many challenges, things like heart failure, valve issues, vascular diseases like PAD and aneurysms.
And those dangerous clots, DVTs.
Right. And then we saw how absolutely critical oxygenation is, looking at the respiratory system, oxygen therapy, and those various infections that threaten our breathing. It's just undeniably clear that these two systems aren't just complex, they are so intimately connected and, frankly, incredibly resilient.
Indeed. They work together constantly, moment by moment. And, it raises an important question, I think, for you, the listener. Given the sheer complexity and, as you said, the astonishing resilience of these cardiovascular and respiratory systems, what's maybe one surprising takeaway for you today about the human body's incredible ability to adapt and sometimes heal?
That's a great reflection point.
And maybe building on that thought, what's one small practical thing you could maybe start doing today or this week to better support these absolutely vital systems within you, even if you're not in the healthcare field, just as a person living in your body?
Fantastic. That's a really powerful thought to leave everyone with, hopefully inviting you to see your own body with maybe new eyes and certainly a new appreciation. We really hope this deep dive has given you a newfound understanding and armed you with some incredibly valuable knowledge to help you appreciate and maybe even protect your most vital engines.
Keep exploring, keep learning.
Absolutely. Thank you so much for joining us on the deep dive.